Okay, so welcome officially to the 23rd episode of Miraculous Mondays, this time happening on a terrific Tuesdays. As I told you, there was an emergency in the clinic yesterday. So because of that, I had to postpone the session at the last one. So never mind, we are there, still there, maintaining the continuity without any, you can say, delay or without any missing of the episode. So what exactly is in store for today? Again, a very wonderful topic for today. But before I begin, of course, as usual, all my presentations will always begin with thank the Lord Almighty has given me much more than what I deserve. And this is my brief CV. You all are aware of it by now as to what I hold in my portfolio in that sense. So today's topic is decision making. Decision making in the clinic because we all know that there are certain times when we have to make quick decisions in the clinic, sometimes calculated ones, sometimes you can say great ones. But all these decisions, when they collectively decide the output of the clinic. That is why they have more importance for us because risks, rewards, impacts, everything is related to you can say in close proximity to each of these. So let's not waste much time over this. And what exactly is the topic? So the art to make calculated but quick decisions in your clinic. So before I begin, I always ask, what who makes the treatment decisions in your clinic? Whether we say it or not, whether we want to believe it or not, many a times decisions are taken by our patients. In spite of the fact that we are the owner, we are the person in the chair, we are the one who is responsible, but still those are taken by our patients. So sometimes they are Google defined treatment plans also. Whose call it is? Of course, the debate is open for everyone to realize. But then this is one art. I'll share a few case studies with you, which will make you believe that sometimes the patient is the deciding force. Many a times we don't have the courage to say a no to the patient, and we don't want to, you can say, make our patient feel that no, we did not accede to their treatment plans. So let me first give you an analogy on decision making by an example of a failed endodontic case. Of course, for every failed endodontic case, whether done by you or whether done by someone else, the decisions are needed in deciphering the cause of failure and, of course, what action is needed as a part of managing those failures. Of course, not in that particular case, but in all the subsequent cases as well. So it is all about the decision making process. Trust me, guys, I had a patient in the morning, just today morning only, and he had a root canal followed by zirconia done from someone. Went to a local hospital where the system is followed that the patient goes to the file counter, then the registration happens, then he goes to the diagnosis room where a lot of interns surround him and start taking his history taking and fill up 2-3 pages of history taking, and then the maybe the junior associate makes a diagnosis and writes, and if needed it is a routine case or not, depending upon the urgency, depending upon the availability, depending upon the resources, the senior associate or the in charge may take a look, or else the patient is sent to one department, then to another department, then to another department to have an opinion. The patient was flabbergasted when he first came to me. He said, I'm shocked. How do these colleges, do these hospitals work? They are making a fool out of us. I said, what happened? Then he narrated me the whole story. I just had a smile on my face. Of course, it was a compassionate one. But this is sometimes you can say he was advised a repeat root canal. He just had a minor food lodgement problem, which was missed in the diagnosis. So a simple problem sometimes is overestimated. When did the root canal happen? The root canal happened 2 to 3 months back. He said, I have some discomfort. There were still periapical changes available yeah, on the X-ray, which is absolutely normal for a healing root canal. Sometimes the symptoms in the radiograph do not disappear after 3 to 4 months as well, or normally they take 3 to 4 months to disappear properly. But this is a small thing which is missed in diagnosis. What is the time duration of treatment and what is the patient's current complaint? He never said, I have pain. They were advised from apicectomy to repeat root canal to removal of zirconia to a faulty crown. On the face of it, I saw the case clinically and on the radiograph also. Their radiograph, I took my own radiograph as well. I didn't find anything faulty. Majorly, in respect to or with respect to the treatments advised, as gruesome as apicectomy. Not that apicectomy is as gruesome as a procedure, but To perform a AP treatment, this kind of a tooth is actually gruesome, which might be a case of misdiagnosis. So it is all about decision making. Who makes the final decision? I have bore the brunt of the same in my college days. The same system was followed in my college. Of course, I was in learning phase at that time. And trust me, guys, the patient came to pedo department. The diagnosis had written extraction of upper three advised. The patient was about 14, 15 years of age. Never had I had the same acumen at that point of time that I would be doing it. I gave the LA and extracted the tooth, the upper maxillary canine in a 14, 15-year-old. It was supposed to be an ortho case. It was supposed to be a consult sent to the ortho. But again, I did that stupidity at my third year. I'm admitting that in fact. And when my, you can say, department, not the in charge, but the junior associate came to, she said, "What did you do?" I said, "Ma'am, I extract the canine." "What? What did you do?" "Ma'am, I extracted the maxillary canine." "You extracted the maxillary canine?" And she was like, as if I had murdered someone. Of course, it is akin to a murder in a growing child. Of course, you can say extracting the canine. I believe that. I believe that. But in those days, when you don't have the knowledge of these things, these sort of things used to happen. But then, of course, that was not the end. The whole, you can say, even without the social media in the 90s, the news spread like a jungle fire. And to all the departments, this third year stupid boy extracted a maxillary canine. It didn't stop there. It reached my hostel as well, the boys' hostel, of course. The girls' hostel might have reached as well, but then mine was none of a concern in that matter. I didn't have a girlfriend also over there. So, अब इसके बाद कोई और बनती भी नहीं. Whatever I did in third year in that particular incident case, of course. So, anyways, then the news spread to boys' hostel. Everyone was looking at me like that they were actually pious souls of God Almighty, and I was the only criminal living amongst them. And I was thinking, what did I do wrong? The diagnosis people decided it. I acted on their command. They had to write room number 5. They refer to room number 4. So it is their fault. Never it dawned upon me that I should have consulted my senior. It is a canine which is useful. We had not studied orthodontics. We had just studied pre-ortho in, you can say, second year. In third year, there was no ortho. I was not studied ortho. We are just into the clinical things. How are we supposed to know? All these were the arguments that I was talking to myself, giving an explanation. No, all is well, all is well. Of course, all is well was not released at that time, but all is well was going on in my mind, in my heart. That night, I couldn't eat my food in the hostel. This is a very, very small incident that actually changed my paradigm of thinking. Never rely on somebody else's diagnosis. This was one lesson that I learned as early as in my third year. And trust me, guys, I have not forgotten that incident. It was October 1995 or 96, sorry. I was in third year at that time. So I remember those days very, very vividly. So it was one incident that changed my life forever in one regard. But it changed for good. Of course, in hindsight, if I look back, where I studied in Faridkot, you can say the populace total was absolutely, you can say, not in a condition to get a treatment done, especially if we even speak of the ortho treatment. He was never supposed to get an ortho treatment done, but the point is that decision making is sometimes missed. A quick decision making is sometimes not resorted to properly. We don't make a calculated decision. We rely on patients. We rely on patients' Googled opinion. We rely on patients' guided treatment plans. We base our treatment plans on our pending EMIs for the next month. These are a few things, of course. So clinical decision making is a very, very complex task. Normally, you can say it is an intuitive process, more of an art than science. And trust me, when you realize these things, that these things are going to be a part of your destiny in your clinical sojourn, you need to better make good. Of course, as I said, arguments can both be made in direction of being against or in favor. Every situation has two viewpoints. Every situation may have two separately suggested treatment plans. Whose plan is good, whose plan is bad? That time decides sometimes. It is all about balancing both these risks. Let's say, as I gave you an example, it is about a failed endodontic case. So what will you do? Of course, I'll show you the image, of course. To intervene or to wait and watch, or maybe to manage a failure surgically or non-surgically. These are the decisions sometimes we have to make, depending upon just one black and white film, or maybe RVG. That is one diagnosis we have to make there and then. Intervene right now, wait and watch. If you are managing it or trying to intervene, manage it surgically, manage it non-surgically. So a few things, again, many people rely on their old judgments, their old behavior, their old problems, then they make a decision. Like this case. What can you see? You can see a periapical developing, sorry for the quality of X-ray. So a periapical developing in 7. Little bit, probably it might be healing lesion as well. But what I can see here is a proximal lesion here in 6 as well. If the patient has come in throbbing pain, it can be because of 6 also. It need not be because of 7 also. But then certain things are misdiagnosed. These can be shadows also. These can be anything other than decay also. We need to make our diagnosis. I'm just giving an example. Don't take these cases literally. But these are the kind of choices we have to make sometimes. People over exaggerate these situations, especially when it is done by a colleague. They will over exaggerate. If it is done by themselves and the patient brings an X-ray, मेरे को मैं किसी डॉक्टर के पास गया था, I brought this X-ray. He said this is not a properly done X-ray root canal. ये यहाँ से short है 1 mm, 1.5 mm, whatever. I'm just giving an example. The doctor told me this thing. Then we try to justify the same XYZ reasons, whatever. Correct or not correct, it is again out of this thing. What I am trying to say here is that we try to do those things in a different manner when it is treated by someone else, and in a different manner when it is done by us. So why two standards? Why can't we do the same for a colleague as well? Finding the right balance is often, you can say, imprecise, because the intention is to avoid an under treatment or to do avoid an over treatment. In under treatment, you will leave infection untreated and the patient may be at risk of local or systemic morbidity. But in an over treatment, sometimes treating a healthy tooth unnecessarily, or you can say the patient has chosen to live with a chronic symptom-free lesion for the time being. डॉक्टर साहब आप रूट कनाल बोल रहे हो करने के लिए, मेरे को ट्रीटमेंट की जरूरत ही नहीं है, मेरे को कोई पेन ही नहीं है, मेरे को तो खाली है दांत, इसमें खाना फंसा, आप इसमें भर दो. This tooth just has a cavity. I don't have any symptoms. I don't have any pain. Please just fill it. Even if it has an open cavity where the chamber is open and you can feel chamber, you can say or see the canal with your naked eye even, or maybe with a probe. You can feel it. Yes, the chamber is open. The canal is open. The patient says, no, sorry. What do? Sometimes people put a foot down. Sometimes they try to convince the patient. Sometimes give them medicine. Sometimes do a cotton filled with Mocosol or Costnoford, and then on top put a temporary filling. That is how diagnosis and treatment planning is sometimes done in such cases, which is actually very wrong. The problem is the decision-making process starts only when the patient and dentist first meet. It is akin to, you can say, a sales marketing pitch. What does sales do? Sales means for many people, कि जब मैंने sale करनी है, it means putting out my laptop and giving a presentation to the patient that this is how it is done. I believe that is not sales, that is propaganda. Yes, I say it, that is a propaganda. What is sales? Sales is when you ask the patient, what is your requirement? Whether your product fits in or there or not, that is for the patient to decide. The golden proportion is 2/3, 1/3. 2/3 of the time the patient speaks or the sales, the customer speaks. And 1/3 of the time the doctor speaks or the sales marketing executive speaks. Then they have a question answer session going on, that is there. Otherwise क्या होगा, आप अच्छी सी presentation देंगे and you say yes, मैंने सब कुछ बोल दिया, आज कुछ नहीं miss किया, for the first time ever. I've been practicing it since many days now. It was a wonderful presentation. Still the conversion does not happen. The price comes secondary. The patient does not even realize that whether the same thing is suited to me or not, or rather the same thing is needed by me or not. This is the way people see an open cavitation and they start with a presentation of a root canal. This is the way we do it. And the patient is like, doc, मैंने तो अभी बताया नहीं मुझे क्या symptoms हैं. You started on with the treatment presentation that root canal is done in this way, this is manual way, this is rotary way, followed by core, maybe post and core, followed by crown, maybe PFM, maybe zirconia, and like that, and so on. So the data collection has to be in the form of history taking, clinical examination, and any other investigations if needed. Of course, then armed with the necessary information, we can rely on the knowledge of presentation of different diseases. Then we make a diagnosis and then convey the same. Similar case. This comes to us, open cavitation. The patient says, I have no pain. You can feel the probe and say the chamber is open. Says, nahi doc, mujhe bhar do. You, without understanding what the patient needs or not, I'm not saying do a temporary filling kind of a thing. I'm not in any way saying that. But we just see it and try convincing the patient without even conveying whether what the patient needs, what the patient wants. Sometimes the patient maybe has been in just to confirm what it is. Maybe he has been advised a root canal earlier also. So the treatment has to be made on your knowledge of the prognosis of the disease, the effect of different treatment options, the anticipated outcome, and of course, the patient's preference or autonomous choice for treatment in the form of an informed consent. So these are a few things that you need to remember. There may be multiple facets of a treatment. There may be multiple things needed by the, you can say, the patients, but what exactly suits the patient the best, that is for you to advise correctly depending upon your acumen, and of course the patient's wish and will to choose upon a treatment. For example, the patient comes with a missing tooth scenario. You advise right from implants to bridge to Maryland to cast partial, and lastly gum stripper or the conventional RPD. The patient is pretty much affordable, so you can say can afford even an implant easily, followed by zirconia crown as well. The patient cheekily says RPD laga do. And what is the first reaction? You will suddenly your smile turns into a reverse smile. Laughing Buddha turns into a furious Buddha. That is where the difference should not come. That at that point of time, you have to respect the patient autonomy, but yes, have to warn the patient what a gum stripper would do, what the adjoining wires would do in such a case. If the patient still goes ahead, mention the same pros and cons. Of course, there are less of pros, more of cons. Mention the same in the patient consent form and let the patient go ahead with it. Of course, when the patient knows it truly, that it is not designed to be for my jaw, it is not designed to be for the given situation where my other teeth would be damaged, my bone loss would be there, the patients will not pick that treatment option, especially if it is an affordable one. The other factors that come into play, especially for the decision-making part, is the attitude. If the clinician or the doctor believes, sorry, it is my clinic, it is my way or highway, and the patient says, I'm sorry, I have confirmed all these things, I just want, if I am spending the money, I should be taking the final call. The attitude never materializes. Then values, in particular the cost for benefit to the patient. You have to make the patient realize, because it is not the price that matters, it is the value that matters. What benefit the patient is going to derive by spending a particular cost of the service in your clinic. The value is for you to make them believe. Of course, financial resources, one of the big factors, affordability or not affordability. It's not about whether the patient wants it or not, it is about the affordability part primarily. So all these have to be reviewed and of course made an important part when the decision making is to be done. The patient has a pain or not has a pain or is scared of the treatment or is scared of other things, that is for you to decide. So what we can analyze from this analogy of a failed endodontic case that I gave you an example is that good decision making is critical at any stage. It is not critical only at the start. It is critical at the end also. If there is a problem, if there is a failure, intervene or wait and watch. If intervening, surgically, non-surgically. So it is easier said than done, but calculated or a good decision making skill is not easy to master. Many of us face so many decisions in a given point of day, and many of them require us to act quickly. But then sometimes we don't even discuss with our team, especially those who have a big team in the clinic, and give the matter a more thoughtful consideration. You can say feedback or you can say team consultation does matter a lot, many a times. So if you incorporate the same from your team, it will help you to make that decision faster with the buy-in from your team. You might be looking at one angle. The team might be giving you another angle. Team means the staff here, of course. We can then see what we have been assuming for that particular set of treatment and where we might have actually gone wrong. Of course, when you make a collaborative decision instead of being an autonomous or an autocratic person, it does have an impact on team dynamics and clinic culture as well. That yes, I'm not saying about every decision, but in many decisions where you can say you can take an opinion. This is what matters. If you gather good amount of information from the key members or the staff or the you can say the team, it'll help you for long-term success as well. Because sometimes we might be colored by our opinions, by background, by judgment, by interest, or whatever. All of this can lead to a flawed decision making sometimes. Of course, if we are the only decision maker, we are the only one who will be making the wrong decisions. That is where we need to realize that if you are the best in every field of your clinic, vis-a-vis your staff, then you are the worst resource for your clinic. Yes, please mind my words. Please do mind my words. If you're the best in every department of your clinic, you're the best in marketing, if you're best in sales, if you're best in sales pitch, if you're best in convincing, if you're best in treatment part, if you're best in managing, if you're best in record keeping, if you're best in everything, the staff will say, wow, boss, well done. And they will say, हमारे को तो सिर्फ झक मारने के लिए रखा हुआ. This is the way the culture is set up. A 360-degree feedback where you take it from various sources, various employees, various colleagues, staff, associates. It has its pros and cons. Of course, I told you about the pros part, but of course, the cons part, it focuses on employee weakness also and shortcomings. That what a stupid idea he or she gave. Of course, they can game the process as well. And of course, it requires more degree of data collection and processing. And sometimes some brains don't process as fast. So imagine being in a staff meeting and you saying, we are going to make this decision before we finish with input from every one of you. Of course, every staff member is then going to contribute and say, yes, yes, boss, I gave my opinion. So all this puts together the point that yes, all voices in the office, in the clinic were well heard before you can say a decision was made. So this is the carry home gyan for today. If effectively used, feedback can inspire, uplift, and motivate the decision makers to make better decisions. If you have not made any wrong decision till now in your clinic, unfortunately, you have not made any growth as well. In larger perspective, I'm talking. Because mistakes are the first stepping stones to success in any clinic. You do mistakes and you grow. Or other people say there are nothing called as a wrong thing. You either make a correct decision or you learn. This is the way to growth. To have feedback, you can get better insights. Your staff members are appreciated for their advice. They feel valued. They feel, you can say, important. The staff culture is, you can say, maintained pretty well. And of course, you can avoid easily preventable mistakes and have more profitability in practice via those desired changes. So how to make the best decisions? The moral of the story for today. This was the topic. The art to make calculated but quick decisions. Yes, it is an art more than a science. Who makes the treatment decisions in a clinic? You or you plus your stakeholders or the staff. The patient who pays or the dentist who treats Dr. Google. None of the above. Not every decision is made by the dentist. It is made by sometimes dentist plus team as well. But surely not by Dr. Google and surely not by patient. That is where the stage is open for debate for all of you. So moral of the story for today is the practice of asking for and giving feedback is not only critical for development but for decision making as well. When we take ideas from staff and team, we can say make the process more efficient. And of course, when you have a good decision being done, it allows us to look back in a retrospective manner and come up with a different kind of a solution, and of course, a more innovative one. So if you are an inclusive leader who takes the opinion of the staff, carries them along with you, you can say that you can get the best possible outcome. Of course, you can make even better decision if you're using the STAR method in your practice. The STAR method is one of the most popular methods used in the industry, and of course, it is one of the answers to the problem. STAR means situation, ST means situation or task, A means action, R means results. So to implement the STAR method, you must first identify the problem, which in our case usually is the lack of information. And lack of information is sometimes we don't let the patient speak. You see an open cavity and start with the presentation of a root canal. You never even bothered. Or you do it in a manner where you believe that sometimes some things are not done in a good way. If you move on to describing action, you can say you can solve all your problems and positive results. But all that is possible if you accord your problems a coveted me time. Think over it retrospectively. How many of you actually, on a holiday, on a Sunday, go and look back at your week gone by? Not in terms of retrospective effect, but in terms of your record keeping. How many of you actually check your record? These are the 10, 12, 15 entries for the day. For the last 6 days, these are the 80, 70 to 80, 90 entries. I'm presuming you're having an OPD of 10, 12 to 15 per day. So how many of us actually look at 70 to 90 entries of the past gone by week and reflect upon this patient did not convert. Maybe I could have talked in this way better. Maybe I could have pitched this way better. Maybe I could have listened to that patient better. Maybe I could have offered a better price. Even some people think that ways. Of course, I'm not thinking that ways. I'm not saying it to do that way, but I'm just telling you these are the few points. Sometimes people do think. मेरे को लगता है मैंने उसको ज्यादा पैसे बता दिए इसलिए नहीं सब कुछ तो मैंने बताया था इतनी अच्छी प्रेजेंटेशन दी थी बॉस उसको चाहिए थी वो चीज के नहीं. The patient came with an open cavity. He wanted you to fill it. You never said that you go on singing the tunes of RCT. Of course, that was needed. I'm not denying that was not needed. But it had to come to a point of decision. The Yeda's formula always say attention, interest, desire, and that is why action and then the selling happens, of course. If you do not create the need, if you do not arouse patients' interest in that problem of open cavitation, that what it can lead to, you are not going to solve the purpose. Then the decision making will always suffer. I hope I'm able to put across what I wanted to and put your brain in a think mode and realign your gears of the brain, maybe light up your bulbs as well. So do tell me if it was a bulb on moment for you. If not, then of course, Ashram Series 3 is there. Japna, my favorite web series. So thank you so much for a patient hearing. And I believe that today's session added some value to you. So I'm running WhatsApp community. The 6th group of this is currently on. It is a purely an advertisement free group. If you wish to be added in there, please do send me a message. I'll add you. These plan to be limited till 6 on. So 6 groups on, and the 6th is on. So this is my YouTube channel by my name only, Dr. Bhavdeep, youtube.com/c/Dr. Bhavdeep. If you forget, just go to YouTube and search Dr. Bhavdeep Ahuja. If you have not subscribed yet, do subscribe and hit the bell icon. I keep on posting these videos every alternate day. At least 3 to 4 videos come up every week. So as on 31st of May, more than 480 plus videos are already there. So do send me valuable feedback on my message, on my WhatsApp, in my groups, and on my page, wherever you're watching it. Book and book bats both will be welcome equal measure. Of course, the stage is open for debate for what I said in today's session as well. So thank you so much once again, and I stop my share for question time and acknowledging the visitors on my page. Okay, Thank you. Hello, Dr. Vinita ma'am. Hello, Dr. Rishikesh. Hello, Dr. Ramchandra. Good evening. Hello, Dr. Raghu. Good evening. Thank you for watching. Hello, Dr. Nikhil. Hello, Dr. S.P. Singh sir. Hello, Dr. Vyangi Parekh. Hello, Raghu. Thank you, Raghu. Different and wonderful presentation. Thank you. Thank you, Dr. Ramchandra sir. Sure, staff feedback does help a lot. So thank you so much, guys, for watching. We meet on Thursday for our Thunder Thursdays, and of course next Monday for our episode number 24. So after the next Monday's episode, we will have a few little changes in the next week because I'll be out for 1 week. But yes, sessions would happen preponed and postponed way. I'll notify in the Thursday and the Monday session for the upcoming 24th episode as well. So this is episode number 23. Episode 24 of finance and 25 of Miraculous Mondays would be a little bit shuffled, a day or two here and there. I'll notify that in the next session shortly. So thank you for watching, and I hope it was some value addition to all of you. Thank you. Bye bye. Take care and have a great week ahead.